everyone, a warm welcome to the ninth module of IIB's EBUS certification course. We are so grateful to each of you for every time logging in huge numbers and for every time sending us fantastic feedback and encouraging us all through to continue with such academic activities. So, as you all know, this is a very unique certification course in which there are going to be 10 online webinars followed by 4 workshops in 4 parts of the country on 4 different Sundays. So, to get the certification, you need to attend at least 8 out of 10 modules live. The other 2 modules could be seen online, but 8 out of 10 have to be attended live. And out of that, after that, at least 1 workshop in any part of the country has to be attended where you'll get plenty of hands on. It'll be only hands on because the theory is, anyways, completed in the webinars. So, this is a very different kind of an initiative because normally in a workshop, usually from 9 to 1, we are listening to lectures, and 2 to 5, we are doing hands on. So over here from 9 to 6, we'll be doing only hands-on, which will give you a lot of confidence, and you'll be taught by the best experts of the country. So with this brief introduction, I think we should get going. Before I start the webinar, I would like to invite you all warmly to our NAPCON Pune. As you all know, NAPCON Pune is being conducted between 23rd to 26th January. It is being conducted by our Indian Chess Society, and we would be extremely overwhelmed and extremely happy if all of you all attend our NAPCON in huge numbers. I promise that it's going to be the biggest scientific feast, and you'll have the best faculty informing you about everything that's new in pulmonology with lots of hands on training in the workshops. And this time we are doing something very special. Every abstract that is accepted for NAPCON will be actually published in a special issue of Lung India. And therefore, if your abstract is accepted, you straight away get a Lung India publication, which is going to be helping you a lot academically also. So please, a warm welcome to each of you to NAPCON Pune, 23rd to 26th January. And now we go back to our today's webinar. So I would like to first call upon the captain of the ship, none other than Dr. Ravi Mehta, who I call as the IP Emperor. We all know he doesn't require any kind of introduction. We all know him. IP has always been his passion. He basically is the founder director of Vayu Chest and Sleep Center, which is end-to-end respiratory care, which is a very unique initiative whereby in one closed center, you enter a center and everything about pulmonology gets checked, offered, and corrected under one roof exclusively on OPD basis, which I think is a fantastic initiative. So hats off to you, Ravi, for this. We all know he's the director, head of the department at Apollo Hospital, Bangalore. He's done his pulmonology training from US. He's certified in IP, he's certified in sleep, certified in critical care, and whatever you want to say more. Uh, to just sum it up, he's the best person to talk to us today. Everything that we need to know about the role of EBUS in benign and malignant conditions. And he's going to be the captain of this ship who's going to slide us beautifully through this today's very informative, brilliant webinar, which has absolutely equally brilliant and fantastic faculty. So over to you, Ravi. Please take over.
Well, thank you so much, Amita, for the extremely exuberant and kind introduction. Sometimes, it gets, you really wonder you've done all this stuff or no, but thank you. Then, of course, thanks to the whole initiative, whether it's starting from IAB all the way to Dr. Nene and Dr. Mehul, who are spearheading this. And of course, a lovely welcome to Arjun, whom I see every week on a webinar anyway. And all the other doctors, Dr. Biraris, Dr. Ajay, Dr. Saurabh, and Dr. Renusha. Olympus and Mankind, I think Mankind, spearheaded by Nitin's efficiency, have been instrumental in trying to get this in the Indian landscape. So thanks to you too. And sometimes it's good to start with thanks because it actually gives you enough time to appreciate people rather than the end when you're trying to wind up and people are rushing towards calls to be made, meals to be had, or family members to be appeased in that order maybe. So with this introduction, we will now start the meeting. I'm sure there's a lot of stuff to be covered. We have with us, the speaker for today is Arjun Srinivasan. I take the liberty of not calling him Dr. Arjun. He's both extremely adroit overall pulmonary and critical care professional and a exceptional interventional pulmonologist who decided to leave us in Bangalore when he came and flirted with us a little and then settled in Royal Care Coimbatore. But with a good friend, Dr. Pattavi Raman, so we bear him no grouse. And Arjun, every time I meet in a public meeting, I will say that to you. Arjun has an exemplary background from PGI Chandigarh, and he after that took it to a different level. So there are few people who can actually go above and beyond their training in a procedural field, and Arjun did that where he has not only mastered the intricacies of interventional pulmonology, but also superseded that by extremely challenging and forward-thinking plural work, which is his forte, and he's known for that. Nevertheless, the regular intervention is part of his skill set, which we'll be taking advantage of today. He has many laurels to his credit, and Arjun, you will forgive me for not trying to extol them in the interest of time. So, with this introduction, Arjun, the forum is all yours, and we start with your talk, which is going to be the flagship talk for trying to take this entire session and build up with an extremely interesting panel discussion with young and productive faculty. Over to you, Arjun.
Thank you, Dr. Ravi, for the kind introduction. And can I share my screen, please? So, very good evening to one and all. And this is the ninth module, and as the IAB March continues, we've been through all the intricacies, all the technical details of doing convex probe EBUS as well as radial probe EBUS in benign and malignant conditions. So it's almost we're coming to the end of the cycle here, wherein it is going to be more of a prospective talk. We're going to be talking about the scenarios where you know the technique, you know how to look at the CTs, but you this will help you in the first few cases. But as you keep doing procedures, like it happens with pulmonology, you realize that the patients do not read the books, and you will be encountering situations which are not ideal, and we'll have to take decisions based on the situations that you'll be seeing. So this talk we'll be trying to look at, is there any way to look at the technical aspects in the perspective of a given patient, and is there any indication as to when do you do what, how to get the best out of each of these procedures, what more can be done in a given patient, is it enough to just diagnose in a given patient, is there a role for ROS to try and look at the nuances, and what is the role of tissue processing, and is there a role for a multidisciplinary team, and whether there has to be a back and forth with your pathologist as well as your oncologist or your infectious diseases specialist or your microbiologist. So it will be predominantly case based, because cases where we'll get stumped, we always do get stumped. And this is about a 53-year-old female homemaker who had no previous comorbidities, and she had presented elsewhere with a streaky hemoptysis of about 2 months duration. There was no constitutional symptoms, and she was admitted in the month of February 2023, and a CT chest gets done. And this is the CT which was done. This is a non-contrast CT that was done there. And you can see that there is a lesion in the middle lobe. And for this, she undergoes a check bronchoscopy, which shows a large clot in the right middle lobe. As most centers have access to a rigid bronchoscopy now, she undergoes a rigid bronchoscopy and the clot gets extracted, and there is a minimal ooze which is controlled with the tranexamic acid. Since there is a quest to diagnosis, a EBUS TBNA gets done from the 4R and the 7 lymph node, and a radial EBUS guided ball and a brushing gets done from the right middle lobe mass, because there is a recent bleed, and this is what gets done. And this is the report which is available. You can see that the EBUS TBNA is sparsely cellular. Few lymphocytes are there, and the pathologist is raising that there may be a small focus of atypical cells there. Radial EBUS guided brush, there are some few rare atypical cells, and the ball cytology is predominantly clot. To confuse the picture further, the ball gene expert shows that there is a very low detection of positivity with the rifampicin resistance not detected. With this, the patient lands up with our medical oncologist, and as medical oncologists do, the patient undergoes a PET CT. And if you look at the PET CT here, you can see that there is a small uptake in the 4R and the 7 node, and mass with where there is a lot of central necrosis and there is a lot of uptake in the mass. So with this, the oncologist says that with a few atypical cells, we cannot go ahead with any treatment, and he wants a definitive diagnosis. So now we have a thing wherein you have a mass which is there, which is highly PET avid, but you have small lymph nodes which are not too PET avid. So if you look at it only from the mass perspective, it looks like a potentially operable case. So we decide to go ahead with a radial probe biopsy of the mass. You can see that this is the middle lobe which is there, and we are trying to see whether we are able to localize the lesion. Seems to be a pretty large lesion, so it should be quite easy to localize. And you can see that this is what would be more like a target sort of lesion there, right in the center. We do a TBNA of the lesion, as well as we do a biopsy of the lesion. Then the 4R and the 7 gets mapped, and both of them gets TBNA and a cryo-nodal biopsy gets done. How you would do for a staging procedure. So this is the histopathology that you can see. So these are the reports which are available, which say that the TBNA from the right middle lobe mass was positive for malignancy, which was called even on ROSE. A TBLB from the right middle lobe mass was poorly invasive, poorly differentiated carcinoma. IHC was possible, and it shows that there is more than 70% PDL1 which is there. And EBUS TBNA from the 4R and 7 node shows only reactive lymphocytes, and so does the cryobiopsy from the node, showing that no evidence of malignancy or granulomas there. BAL of the BAL plus gene expert is all negative, and a follow-up mycobacterial culture which comes on follow-up is also negative. So now the points to ponder here are atypical cells do not make a diagnosis in this day and age. When you have a mass and a lymph node, you always have to review the radiology in detail to look at whether staging is needed and whether you can offer something which is potentially curable at the end of the procedure. If you look at the initial PET CT staging, which look like more like a T3N2, especially with the initial procedure that was done, which showed probable few atypical cells. However, post-second procedure staging was T3N0, which takes the stage down to stage 2B, which means that it is potentially curable. Here, the sample, you have to sample the node first. If it is positive for malignancy, you can avoid a radial port procedure. This is important also because you have a higher yield from a convex probe procedure as against the radial probe procedure. But however, in this case, both the things were needed because this was a potentially curable lesion. ROSE can be helpful. Again, in this case, ROSE of both the TBNA from the middle lobe lesion, which was positive for malignancy, as well as ROSE from the nodes, which were negative for malignancy, helped us appropriately sort of triage the samples that we took. You have to try and get as much tissue as possible, and that is the reason as to why we went ahead and did everything in this case, because this patient was undergoing a repeat procedure. And you have to be careful because we are also guilty of this, because each time if you got to send your samples of your TBNA and your BAL or your tissue separately for gene expert, Sometimes, in a corporate setting, it leads to additional economic issues. But in certain patients, you'll have to be careful that you do not mix samples because you do not know whether you have two different pathologies or a pathology which is sitting there. Now, this patient undergoes immunotherapy with a chemotherapy because she had a PDL1 which is more than 70%. And this goes on for 4 cycles, and the oncologist goes ahead and does a PET-CT. So if you look at the PET-CT here, you can see that there are new highly petavid nodes which have popped up, and the mass has really shrunken in size. So at this point of time, the patient gets referred back to us to try and explain as to what is the reason for this um, lymph node which have popped up. And it is also in the back of our mind that this patient had a gene expert which was positive outside, which was from the BAL, and which we had because we were our gene expert as well as the mycobacterial culture was negative. We had decided to uh, uh, not give much importance. So we went ahead and did a restaging of this patient. We had multiple nodes which were positive. So this was the 7 and this is the 11R which is getting mapped, and subsequently both these nodes were sampled. We went ahead and did both the EBUS TBNA as well as cryobiopsies. We took adequate samples for both histopathology, and we had samples also going in for cultures as well as gene expert in this case. So when you look at the histopathology, you found that there are only granulomas which are seen, which was not there in the previous thing, and gene expert was detected low, and lo and behold, we also had a mycobacterium tuberculosis culture, which was positive at the end of 4 weeks. And the EBUS TBNA cytology also showed granulomatous inflammation consistent with tuberculosis because there was a lot of necrosis there. Patient was started on ATT according to body weight. She completed the 5th cycle of chemotherapy. After the intensive phase of ATT, patient underwent upper lobe and middle lobe resection, which systematic lymph node dissection was done, which was done July of last year. Mass lesion of the right middle lobe was adherent to the upper lobe, so the upper and lower lobe had to be taken out. The lower and so the paratracheal and subcarinal inferior pulmonary nodes were dissected. They showed only granulomas and there was no evidence of malignancy. So this is the histopathology, and you can see that this is restaging, and there is a lot of fibrosis in the histopathology. This is something when you do a procedure after a chemo or especially immunotherapy, you have to be aware of this. So she completed both chemotherapy and ATT. Post 15 months of surgery, she is free of the disease as of November 2024. So here the what are the take-home points from this case is that more than one diagnosis may occasionally be present in a single patient. More common with lymph nodes appearing with ongoing immunotherapy, and this is something that as more and more oncologists have started using immunotherapy upfront or during the course of lung cancer, you're going to find it as a part of what is called as a pseudo progression or the good old sarcoid like reaction, which means that you have to confirm the diagnosis because restaging is essential for prognostication. Here, either a forceps biopsy or a cryobiopsy scores over a TBNA because the tissue yield is better. And we know historically from EBUS TBNA data that EBUS TBNA, when it is used for restaging, has a yield of 60 odd percent only, as against 90%, which you will see with the initial staging. This is because of the extensive fibrosis that happens with both chemotherapy as well as immunotherapy. TB and malignancy can also rarely coexist, or TB can be a reactivation of TB can occur during the treatment because the patient becomes immunocompromised during treatment. Careful sampling, and sometimes you will have to have an follow-up, which is essential. So coming back to case 2, this is a young male. You can see that there is a little bit of a small consolidation. Patient presents with about 4 weeks of cough and constitutional symptoms. And you can see that there is a small area of consolidation and a little bit of central lobular nodules which are there. So this is a bronchoscopy. You can see that this is the right upper lobe. And you can see that this is a anterior, posterior, and apical subsegment. And you can see that this is the so you can see this is the apical subsegment, and this is the posterior aspect of the apical subsegment. And you can see here that everything else is clean, but you can see a small dot of pus which is there in the posterior aspect of the apical subsegment. And when you put in a radial probe there, you can see that this is in the midst of a consolidation here. A ball from this area is shown to be gene expert positive. Similarly, this is a very poorly controlled diabetic patient. You can see a very thick walled cavity in the sixth segment of the right lower lobe. You can also see bronchus, which is leading right onto this. And this is bronchoscopy. You're entering the sixth segment. And you can see that there is telltale evidence of purulent secretions, necrosis, and sometimes when you use an ultra thin bronchoscope and you're not able to see anything, our general tendency is to use suction. But what happens is the airways will tend to collapse. If you use a few ml of saline, then it will lead to a much better vision. And you can see, lo and behold, you are able to see a necrotic tissue, wherein you can actually go ahead and take a sample of this under vision, which was consistent with mucor in this patient, and because the patient had HbA1c of more than 12. So points to ponder in cases 2 and 3 is that you have to look for endobronchial cues. This is especially true in cases of infective nature. Following them in the sense of following them distally using a thinner bronchoscope, you may be able to turn a peripheral lesion chase into an endobronchial biopsy. This can then be confirmed if necessary by placing a radial probe there to make sure that you are in the center of the lesion, which tremendously increases the chances of you getting a positive diagnosis. And of course, you need to essentially have an appropriate size bronchoscope for this. This was a case of a patient who had an exogenous Cushing syndrome, and patient had multiple episodes of severe infections. And you can see that there is a small nodule which is there in the right upper lobe. This was a Dottonac PET after the patient recovered from pulmonary nocardia. And this was the only PET avid lesion which was there, which amounted to about 1.3 centimeters in size. This patient was taken up for radial probe inspection. You can see that since it's an ultra thin, you're going into the right upper lobe posterior, the anterior subsegment of that, then the inferior subsegment. Then you are able to visualize. So you are able to get into multiple subsegments before you're able to visualize the lesion. So now biopsy is taken and it is consistent with the neuroendocrine tumor or an atypical carcinoid. And if you look closely, you are actually able to see the endobronchial infiltration. This is again possible only because you are using an ultra thin bronchoscope and you're able to convert a peripheral lesion into an endobronchial biopsy. So, extending the peripheral reach, this is the role of ultra thin bronchoscope. They have smaller outer diameter and a greater range of motion to improve access to subsegmental bronchi. These include those in upper lobe. So these are usually very difficult to access with the conventional bronchoscopes. Ultra thin bronchoscopes are designed to shorten the distance from the forceps to the lesion, which can increase the diagnostic yield. The lesions which are invisible on conventional bronchoscope sometimes become visible, as we have shown in cases 2, 3, and 4. They have a working channel of up to 1.7 mm. So this is the thin, which is 4.2 outer diameter, whereas the ultra thin has a 3 mm outer diameter. Whereas the ultra thin is able to give you a working channel of 1.7 mm, which means that you are able to pass a radial probe through the ultra thin bronchoscope. You'll be able to pass an 1.1 cryo also through it, but you'll not be able to pass a sheath through the ultra thin bronchoscope. So again, this is in effect what we managed to achieve in cases 2, 3, and 4. This is where the standard bronchoscope would stop, and then you'll have to extend the accessories across. Whereas with an ultra thin bronchoscope, you are right next to where the lesion is, which you'll be able to either visualize it endobronchially itself, or you'll be able to visualize it um, with the radial probe, and then you can use their accessories, and the length of the accessories that is extending beyond, which means that you are not going into any of the blind bronchus, which is not leading to the lesion, and this is where there is an increase in the yield. Coming on to case 5, this is a 69-year-old smoker, diabetic and underlying COPD, cough, loss of weight, and decreased appetite of about 6 months duration. And if you look at this CT, you can see that the underlying severe COPD patient has a right upper lobe lesion, which is quite speculated, and patient also has a left lower lobe mass lesion. And similarly, the same thing can also be made out in the contrast mediastinal section. And when you go ahead and do this, so the instinct would be to try and see whether you can do a radial probe EBUS for this. But surprisingly, when you have something which is quite proximal, a lot of these lesions can actually be sampled with a convex probe ultrasound. So when you use a convex probe ultrasound to sample central pulmonary lesions or the so-called peripheral lesions, you will be able to see the lesion in real time, wherein you are able to sample the lesion in real time. So we are trying to reach for the lesion which is in the left lower lobe, and you can see that the entire mass is seen there. So this is something, this is a trick which has been in use right from the time EBUS has been available in India. That is from the first publication came back in 2008. And there are more than 14 studies with 1,200 patients, wherein the diagnostic yield is equivalent to or maybe even better than a CT guided biopsy for peripheral lesion, which is our main things that we argue about with the radiologist when you're looking at why do you want to do a radial probe when you can do a CT guided biopsy. But when you are able to reach it with the convex probe and you're able to sample it in real time, and especially in the current scenario where in addition to doing a TBNA, you're also able to do a biopsy, which might be a forceps biopsy or a cryobiopsy of these lesions, then the possibility of diagnostic yield is more than 90% in or close to 90%, which is what a CT guided biopsy will get you. So coming on to our last case, this is the 60-year-old diabetic, fever myalgia for 1 month, labs and cultures, CSF analysis was normal because the patient had significant headache, and evaluated CT, MRI, brain, and PET. PET showed multiple enlarged mediastinal lymph node with intense uptake. And this is the lymph nodes which are being sampled. So here we went ahead because we were not really sure of the diagnosis of this patient, and multiple rows. The call was only mature lymphocytes. We went ahead and in addition to doing EBUS TBNA, we went ahead and did a cryonodal biopsy as well of the nodal. So this is the cryo probe which is entering, and we have taken a cryobiopsy also as well of this. And when we looked at the histopathology, the TBNA showed only mature lymphocytes, whereas the cryobiopsy on histopathology showed us features consistent with a low-grade non-Hodgkin's lymphoma. So now summary and take home is that whenever you're looking at a patient, you'll have to look at and review the radiology. You have to look for whether staging is indicated and whether staging is a possibility. You also always have to look for endobronchial cues. If the patient has had a history of hemoptysis, you might be able to see a trail of blood. This might be possible even if the patient has a very tiny nodule. You can find a trail of blood, or sometimes find a small clot which is sticking out, which can guide you to the appropriate segment. If you're looking at an infective lesion, then you will be able to find sometimes uh, small dot of pus, especially if the lesion is very small. Or you might be able to find endobronchial necrosis. This is more common when you're dealing with fungal infection, especially mucor. If and it is always, if it is possible, use a thinner scope. Always there is a trade-off when you use a thinner scope, and if you encounter hemorrhage, then you are not, you may not be ready to handle the bleed. But if you are able to reach distally, and even if you are able to just take a lavage from the distal place where there is a lot of endobronchial involvement, the chances of yield would be much better than taking a lavage, which is more proximal. An endobronchial, by which I mean a thin scope biopsy, will have a better yield than a radial probe guided biopsy, because you are farther distal and you are nearer to the lesion. You always look whether a convex probe EBUS guided biopsy or TBNA is feasible, because a convex probe EBUS always has a better yield than a radial probe EBUS. When using radial probe EBUS, use as many accessories as possible, which may be a needle, which can multiple needle can actually turn your eccentric lesion to a concentric lesion. You can use a biopsy subsequently. You can use a brush. Our own bias is more towards cryo, especially with the 1.1 cryo being available. When staging, you always follow the protocol and make sure that the tissue is properly processed. And you'll have to, the protocol is to always go from N3, N2, and then N1. Rows can help in appropriate utilization of tissue, because you can't keep on sampling till the cows come home, because rows can definitely help you prioritize how you want the tissue to be utilized. And this can also be, in the modern times, you can have a lot more tissue going and being preserved for next generation sequencing, or if you want to look for either PDL1, or whether the patient is a candidate for immunotherapy. When the clinical, radiological, and the ROSE data are not in sync, you need to get your big guns out, which means that you probably will have to look at whether you need to do a forceps biopsy or a cryobiopsy, which might be either in case of a radial probe or in case of a convex probe also, and grab as much tissue as possible, because you do not want the patient to undergo a repeat procedure as much as possible. Thank you.
Thank you very much, Arjun. Very interesting. And to put it into perspective, Dr. Arjun has not only gone through case-based discussions, but he's also put a lot of practical perspective. It takes around, I think the unit must have done some 4-5K EBUSs, 4-5,000 EBUSs, if not more. And it takes a lot of practical perspective. So the good part of having such talks is that not only do you get the perspective of what is going on, you get a perspective of what lessons you can learn, which others have taken months and years to learn. So, and it has been excellently divided into procedural aspects, technology aspects, tools aspects, what to target or next level, and so on. So, Arjun, that sets the stage for our panel discussion. And at this point, after this lovely preamble to detailed talk, we will now introduce our panelists. Nitin, can we have the slides? Okay, good. Great. So it gives me great pleasure to introduce Pawan Biraris. Pawan is not only a accomplished faculty in Tata, as well as an interventional pulmonologist in the private sector in Apollo, but he's also personally very close to us, because he's been both a colleague and a friend for many years. Welcome, Pawan. It's a pleasure to have you here.
Thank you, sir.
Next faculty is Ajay. Ajay also has been, not only silently creeping, but now leaping in the landscape of interventional pulmonology. After doing his training from Delhi, he is now the leader of the IP unit in Trivandrum, KIMS Trivandrum. And we've interacted on several meetings where we are very impressed. And last time when Ajay was speaking on CT bronchoscopy correlation, showed a lot of depth of knowledge. Welcome, Ajay. Dr. Saurabh Ahuja comes from a formidable background from the All India Institute, and now he has settled in the Amrita. So there is a tinge of you of the South Saurabh in you as you made your way to this huge facility which came up in Faridabad. It's a pleasure to have you here, Saurabh.
Thank you, sir.
And Dr. Renusha, I think, comes from Dr. Nagarjun's unit where she is an intervention pulmonologist. We also interact regularly. Welcome, Dr. Renusha.
Thank you, sir.
Okay, so with this extremely interesting and accomplished faculty, we start our panel discussion. Let's now build upon what Dr. Arjun and the last 8 months. So it's a formidable task, and both Dr. Amita, Mehul, and Nitin have put the burden on us more because now we are supposed to take all what has been covered in 8 sessions and try and give more meaning so that the audience can benefit, especially those of you meticulous people who've been logging on every time and trying to gain the most of this. So let's start with Pawan, and you guys will forgive me for using your first names. I think I have too many gray hair to call you by Dr. Pawan and so on. So Pawan, EBUS has been around for a long years. To the left of your screen is this gentleman called Arjun who comes from Dr. Pattabi's unit who went over to Japan, worked with Dr. Yasufuku, came back to India, bought the first EBUS in the country, extraordinarily expensive and extraordinarily innovative and entrepreneurial as he bought from a third agency and so on. And then that is the beginning of the EBUS march or gallop, which happened later. So how do you want to comment on EBUS versus prior modality? And now I'll give you more things. My more famous namesake is Dr. Mehta, who basically has been espousing the cause of conventional TBNA for so many years, 1973 Copenhagen. So 73 to 2008 and 2008 to now. How would you put EBUS compared to prior modalities? And since you're a Mumbaiite, we'll throw a second question in. In your part of the country, people keep on putting needles into the mediastinal lymph nodes, which both is a horror as well as a unusual thing for us to see. Can you combine all of this and give us some answer on how we can learn from all these things?
Yes, sir. So I'll need a minute extra to answer this question because when you start journey from 1978 till 2000 and 2024, there are too many things to address. When you look at the mediastinal lymph node evaluation or any lesion evaluation, we look at conventional TBNA, CT-guided biopsy, surgical sampling, and then EBUS and EUS, which has come and it has taken a central role recently. So in malignancy, especially, we talk about lung cancer staging, and that's the area of interest where we need to target multiple lymph nodes systematically, and we need to target 5 millimeter node and more sites. So when you look at the even in literature of conventional TBNA, the sensitivity is less than 40% for staging EBUS. Even for smaller size lymph nodes, it's difficult to. It is possible, but it's difficult. And it doesn't gives you better advantage than an EBUS TBNA. CT-guided biopsy in lung cancer staging, definitely no. It has its role in lung masses evaluation and certain situations like lymphoma where it has been rampantly used in a city. When we talk about surgical staging, sir, we talk about mediastinoscopy, and it has been gold standard for years together and has been compared with EBUS TBNA. In mediastinoscopy, the disadvantage is that it gives you access to very few nodes like paratracheal and subcarinal lymph node, while EBUS gives you access to all the possible nodes in the mediastinum systematically. The mediastinoscopy also requires a GA. It requires a skilled surgeon. So EBUS has taken over from 2019 onwards. I think EBUS and EUS combined together has become a central node in lung cancer staging. What we do at present, where the role of EBUS compared to these modalities is that we do staging with EBUS, and those negative results of EBUS are reconfirmed with mediastinoscopy, so that we reduce the unnecessary thoracotomies, and that's been a protocol so far. Last year, another trial has come which showed that the EBUS has equal efficiency and sensitivity compared to mediastinoscopy, and in fact better. So only do EBUS, no need of mediastinoscopy. So EBUS is going to be the investigation of choice in lung cancer staging per se. When you add EUS, it gives you access to the inframediastinum as well as the adrenal and the liver. So it enlarges it extends our horizon to access the entire mediastinum. So currently, EBUS is the investigation of choice. Only upper hand mediastinoscopy has the station 5 and 6, which are difficult with EBUS. And the favorite investigation of Mumbai, probably CT guided biopsy, I see role mostly in lymphoma cases, sir, where if EBUS TBN is negative. But as Dr. Arjun has shown, the cryo and the forceps biopsy are going to replace it further. So CT guided biopsy definitely no. EBUS is central road. Mediastinoscopy is only for the evaluation of EBUS negative samples.
So excellent. So to put it in perspective, what we had before cancer, I think, was largely a very empirical science, and EBUS has taken it to a very specific science. That's one carry home message. What we had was CT scan, which ultimately had only so much sensitivity and specificity. We went to a PET where radiology actually surpassed us in speed, and the PET was used as a staging tool without tissue. We had conventional TBNA, more a Western tool than an Indian tool. And so, though some of us did it and published also, we could not get conventional TBA to come in. And EBUS added the major component of visual, dumping down the procedure so it is much easier to both teach, learn, implement, and execute in your setup. And then came the aspect of fact that we realized that there is so much more cancer. And then to borrow from Arjun's word came treatment, immunotherapy came. So suddenly the stakes became very high that both diagnosis, accurate diagnosis, immunohistochemistry, and staging are important to make a difference. And that is why probably EBUS has been a game changer for diagnosis of malignancy. As of now, half of what I said is history. For now, it's going to be your PET and your EBUS. All conventional TBNA, mediastinoscopy, and empirical treatment has now been relegated to the background in a very, very fast amount of time. So sorry for the detailed thing, but I wanted to put this important point of which Pawan nicely brought up into perspective. So now let's shift into brass tack stuff. Ajay, let's get down to what people want to know. What is the planning you do for EBUS in a suspected malignancy situation, and how would you detail it nicely? In a minute, if you could tell us. Unmute, Ajay. Still not audible. Not yet. So maybe while we're waiting for Ajay to unmute. Now you're audible, Ajay, I think. Not yet. Okay, Ajay, while you figure it out, I'll leave this question to you. Saurabh, let's pivot to you and say, let's talk of the word staging EBUS, which Pawan brought out and which has been the major claim to fame of EBUS replacing mediastinoscopy. Very rarely in the history of medicine do you have a medical procedure replacing a surgical procedure. Can you tell us about your approach to staging EBUS and more important and equally important in the Indian setting, how important this is?
So if you ask me the importance of staging EBUS, if we get a patient, especially for staging EBUS, who has already been diagnosed a malignant lung cancer by maybe a CT guided biopsy or something like that, and where they are planning that the patient is to be posted for surgery, the first biggest challenge in our country is going to be the treatment, could be the cost of the therapy, cost of the procedure, because they already know that they had to undergo a surgery, and then before that, if you ask them to pay, especially in a corporate hospital, maybe a 40, 50, or 60,000 rupees for a staging EBUS, that is the biggest challenge. But somehow we try to convince this patient because we know that the surgical staging will definitely differ if you sample a node which is on the contralateral side and which comes out to be positive. As far as the procedure point of view is considered, for my younger colleagues who have joined and who are now going to start their career in this intervention pulmonology, the key home message is that whenever you stage a cancer, you have to stage from the contralateral side. The biggest challenge, if you go with the guidelines, if you say, is that you have to use ideally a separate needle. But again, this is the biggest challenge in Indian continent, that we can't use a separate needle for that. And the most important thing which you need is going to be a pathologist standing with you so that you reduce your time. But all of these things, in an ideal setup, you will have a pathologist, you will have different needles, you will have a good anesthesia backup, you will have everything at your disposal. But in our continent, in our part of the country, we all know that majority of the things are not available. So in my center, what we do commonly, we start from the distal most node, which is on the contralateral side, maybe N3, then N2, then N1, use a single needle, try to take as many passes from as these nodes are there, and to send them separately to our pathologist, because also we don't have the availability that a pathologist is standing always all the time for sample for the rows of these lesions.
Okay, so what Saurabh is trying to say is that staging EBUS is a challenge. Okay, so I'll come back to that later. But by and large, don't forget, guys, that the major claim of EBUS in replacing mediastinoscopy in the Western world was staging. Why? Because as we were quietly trying to do intervention pulmonology, lung cancer literature was galloping on the fact that stage decides outcome. And that is the biggest message out there. And so accurate, obsessively accurate and meticulous staging became the mantra of lung cancer uh, uh, approach and treatment. So in such a situation, staging became important, and that is where it took around, I think, Arjun, if I'm not mistaken, a decade of literature to try and show that EBUS will be plus minus EUS, and now EUS is by and large taken out, is the way to go, and nobody accepts it. Surgeons have stopped fighting, pulmonologists have accepted it, the skills have picked up, and it has reached a absolutely unequivocal guideline stage. So if you have a cancer, you're supposed to stage it. Simplest mantra is if you have a lesion on the left side, you start from the right distal most node and come here. It's not difficult when you start doing it. You have to do the, just slides have to be sent separately. But keep your time for it. Don't be in a hurry to do a staging EBUS. It's going to take you 45 minutes or so if there's multiple lymph nodes, maybe 1 hour. And that is your duty to the procedure and to the patient. Now, coming back to Saurabh's point, I like to add something that when we ourselves published in 2016, I think, and the first 1500 EBUSs, we looked at the prevalence of staging EBUS requirement in India, and that was 12% that time. But by the time we've hit 2022, it's gone up to a good 15 to 20%. And I'd like to ask Arjun also. Arjun, what is your, in your large series of patients, what is the requirement for staging EBUS?
I think, yeah, we looked at it when I think Dr. Dheeraj had asked us to look at what is at the time it was about 5 to 6%. This we're talking about 2015, 2016, and no, not 2014. And I think in recent times it's about 10% in our thing, and that would also be like these nodes which pop up after immunotherapy, and these nodes which pop up after chemotherapy, and it may not be considered to be staging in its what do you call that as in its literal sense, because a lot of these patients do not get subjected to surgery per se, but it does lead to a change in the chemotherapy or the drugs that are being used to treat these patients, because it would mean that the new nodes which have popped up and you say that these are cytology positive, then these guys are going to get switched to another set of drugs which are available, or immunotherapy which is available. And sometimes we do not have adequate material from where we started off, and saying you might have to do a biopsy for a PDL1. So those are the increasing indications for restaging rather than staging per se.
So one of the reasons to put this into perspective is for the listeners is that because our patients come late, that is why staging EBUS is less done. You can't take away the science. It's a very important thing. Still, staging decides your outcome, whether it's your exam, it's your practical case, or it's your own family. Staging decides outcome. But because our patients come late and the disease is right shifted, we have a lesser requirement. So nevertheless, the science doesn't change. So these are the good points brought out by our faculty. I think Ajay is now voice worthy. Ajay, you are audible as well as visible, I think now. Let's get
Yes,
back to your question.
my
What is your prep for a EBUS in a malignancy situation, and what do you do in terms of investigations and approach? 1 minute for you.
so I think I'm audible now.
Very much, very well.
So sorry for the technical glitch. So basically, patients comes to us with a suspected malignancy. They may be referred from outside. They may be already having a CT scan. They may have tried a bronchoscopy or maybe it can be a thoracic malignancy or it can be a extrapulmonary malignancies. So according to the planning, regarding the planning of the routine investigations, whichever as much as not required for an EBUS, maybe a hemoglobin and platelet count, maybe a basic routine which we may need, and maybe the viral markers for the safety of the purpose. But when you go for the when I talk about the specific things, a good quality contrast CT thorax of the chest is the must thing which we need to have, which to be a recent one for planning and go ahead for a EBUS. So a contrast CT which with, if possible, with the thinner cuts and that with the on a packs model, because that helps you to plan to see the size of the nodes, to see which are the nodes which are more, which has to be targeted, where to be targeted, how many numbers, whether there are other lesions, other masses, all this thing is required. And if in case if you have a pet which is well and good, so that we can target it according to that which increases the yield, where which nodes to be and where to target at which nodes, where it is. Also, it also helps us that when the nodes are bigger and when the infection is also a concern, or there are bigger nodes with necrosis, where to target. So basically, we'll have a contrast enhanced CT before going in and planning the EBUS these things. And when
any other tests or preparations you will do specifically from the malignancy point of view besides staging?
Sorry?
Any other tests or anything else you would do specifically?
For the?
From the EBUS malignancy, we're saying malignant patient coming with suspected malignancy. You've done your contrast CT or your PET scan. Any other specific preparation or testing you would do before the procedure?
So one thing which I usually we should have a basic bronchoscopy examination of the airways, so that we don't miss any endobronchial lesions or any other lesions, because any stenosis. And also, it's always a practice that you proceed with your EBUS examination with a basic bronchoscopic examination, so that you don't miss it and all this. That is what specifically what I look for before doing considering an EBUS.
Okay, excellent. So by and large, contrast CT is a must, guys. No one does now EBUS without a contrast CT. And actually speaking, if you have the infrastructure, in modern times, it's a PET. Please do your PET before you go ahead with a EBUS, because that's the only way you're going to talk size, how hot it is, what the nature of the node is, staging, and so on. Of course, resource limited settings is not a part of what we teach, but that's a very important thing. Let's shift to Renusha now. Renusha, we've done all this planning. We've got a contrast CT, PET. We're talking about all this. We know how to do the procedure now. Now comes the menu card of tests, which went from, to use the old days, it used to be a small landline phone, a small phone, and now it's gone into iPhone, Samsung, Vivo, this, that. So many tests are there. What tests? How do you integrate with the oncology? What do you decide what to do in which patient, and how do you plan your procedure accordingly?
So firstly, when it is coming to malignancy, in order to confirm if the malignant cells or atypical cells are there or not, we have to always start with cytological analysis and histopathological analysis, where we will be knowing the morphology and cancer can be confirmed. And then once we confirm the cancer, the presence of cancer, to know what type of cancer it is, then comes immunohistochemistry testing. So we have all our IHC markers to know from where it has come. And then once we have diagnosed that it is this type of a cancer, to know to further go ahead with the treatment, there comes our molecular test and next generation sequencing. Like in cases like lung cancer, where we need to know what are the mutations present in the patient, so that we can divide into targeted therapy, immunotherapy, and all. Like basic things like EGFR, ALK, ROS, and PD-L1 are the basic stuff in NGS testing and molecular testing, what we do. And then there are like 12 gene panel, 52 gene panel, where all the possible mutations can be identified. If the patient is affordable and if that is required, we will definitely send for those testings as well. And then if you're suspecting lymphomas, then flow cytometry is also it will be useful to determine the cell lineages and also immunophenotyping. So basically, for any person with malignancy, these are the tests which we will be doing.
Pawan, you come from the Mecca of oncology, Tata. How do you decide what patient to do? When we do this, I remember the original days, the oncologist used to walk in, look at us and say, how are you going to get me enough material? And the surgeon used to be waiting in the background saying, these guys are never going to get enough material. How do you triage this? Secondly, this would probably be, say, a huge amount of money. What is your strategy to triage the tests and integrate with oncology so that you continue to do justice and also get your patients for the procedure? Unmute, Pawan.
So, sorry. So at Tata, sir, we get majority patients who are already diagnosed and then referred for management. But if I look at a naive patient who is not with diagnosis, we have a treatment naive patient with no diagnosis yet. I have a parenchymal lesion. I have metastatic lymph nodes. Depending on the clinical staging, on basis of CT and a PET, we define the stage. If anybody more than 1B staging requires an MRI, then. And if the MRI is positive, my diagnosis changes and the treatment strategies changes, that this patient will be not for surgical management. This will be a chemo or a molecular marker positive. So then the requirement of tissue comes in. And I would like to do a diagnostic transbronchial biopsy or cryo and EBUS in one setting if given a chance. and set up the tissue from the mass should be preserved as much as possible, because lymph node yield will be either malignant or reactive, but you may not get the enough material. So combine these samples together. Now coming to triaging the sample, a rapid on-site evaluation definitely helps. Like you start from N3, N2, and then N1. And I would like to highlight here that N2 has to be sent separately, because N2A and B, like a single station N2 and multi-station N2, the treatment is still single station N2 can be a surgical candidate, multi-station N2 is a medical management or a CTRT management. So send the samples separately as much as possible for the N2 lymph nodes. Now coming to what samples to be sent, if you get granuloma during the EBUS TBNA, you need to triage that sample for microbiology as well. But when you look at only malignancy and it has shown...
Pawan, sorry to interrupt. I'm going to ask you a practical question.
Yes.
You're giving me lovely knowledge. I'm saying I have 20 tests. What do I do? I've taken a sample now. What am I going to send off?
So first should be diagnosis and whether adeno, small cell, or carcinoma, which is IHC.
Exactly.
That's it. There you stop. Here the patient is surgical candidate. You send a sample and the entire surgical sample can be used for molecular analysis, whatever they want to do in future.
Yeah.
If not...
To crystallize... sorry. Yeah.
So if not, then the basic requirement is EGFR, ROS, ALK is the basic requirement where you have medications to target.
So let me make it simple for you guys. First of all, I think you can go on in India, and this is not the Western world. If I put a litany out there, I have no money left for treatment. Diagnostic procedure has depleted the patient, and Saurabh will even shake his head more in agreement because. So by and large, what is practically done is first get a diagnosis. 2, save second material for IHC. 3, talk to your pathologist and make sure they don't take enough cuts that they cut off the whole sample only and you have nothing left with you. So you make sure that you talk to the pathologist and they save enough material. Third, then you plan for whatever targeted molecular markers are there relevant to therapy. For that, you can save the sample appropriately. Thank God that's available. Blocks are available. And lastly, if the stakes are very high, then you will go ahead and do further biopsies, which is the question coming to Arjun. So I think that's a very practical way of trying to say that how you're going to go. In that way, you also make it appropriate to the patient. Because otherwise, if you don't link the dots, and that is your responsibility, if you don't link the dots with the original diagnosis and the pathologist and using sample appropriately, you will basically have half a EBUS, and this is an entity not talked about. Half done EBUS with diagnosis is currently an inadequate EBUS. After 15 years in India, we have to admit, only getting a diagnosis is never going to be happiness. It is all completing the diagnosis to the point of linking to therapy, which has to be understood by the EBUSologist in the right sense. So with this in mind, we pivot to Arjun and say, Arjun, where the stakes are the highest, lymphoma, where if you don't do an IHC, you don't do markers, you pretty much, there's no point doing it. Then you have to hang your head in shame and say, the CT guide guy would have done better. What is your strategy? I know you've touched on it partly, but you want an accurate approach to of Arjun and science to lymphoma by EBUS.
So whenever we have either a clinical suspicion of lymphoma or when our clinical, radiological, and what the pathologist is calling on rows, we keep on doing the sample and you keep switching the nodes and still all you get is either reactive lymphocytes or some occasional granulomas or some histiocytic aggregates. So that is where the usual antenna goes up and you say that this patient, whether you do a biopsy for other patients or not, this patient would need a biopsy of these lymph nodes. So the strategy before, say, 2018 would have been like whenever there is a clinical possibility of lymphoma, and when we had a surgeon who was willing to do a mediastinoscopy, we never used to subject them to a procedure which was probably about 45,000 then, and say that at the end of the thing, maybe lymphoma and you need a mediastinoscopy for confirmation. So that is what has changed from 2018 to 2024 or 23. 24 is that now we go after these lesions with either a forceps biopsy or a cryobiopsy. Our own bias is for a cryobiopsy, and when we do a cryobiopsy, we'll make sure that we get good 3 or 4 chunks of tissue from each of the nodes that we're sampling. If you've got to sample 3 or 4 nodes, go ahead and take three chunks of tissue, because there is not much data. It's going to be only case series or case reports wherein you're going to get reports of lymphoma, because when we looked at our cryobiopsy series of close to 2,200 patients, we have had 5 patients of lymphoma, which means that you're looking at a 2 or 3% chance of you hitting lymphoma, which means that these patients you'll have to go hammer and tongs, take as much tissue as possible, send some of these tissues out, and we prefer to keep some of these tissues so that because sometimes, like Dr. Ravi said, sometimes these tissues go. Sometimes these also have to get outsourced, and the blocks go out and nothing comes back. You don't get a diagnosis, and you don't get the tissue back either.
Excellent. So I think the bottom line over here is lymphoma is the highest subset for diagnosis. If you're going to use EBUS for lymphoma, you have to use the old yield was around 65% in lymphoma using regular EBUS. Using the more modern techniques and cryo and all, you can take it to a much higher 90%. It's very important to alert the pathologist you're looking for lymphoma. A PET CT would be a very important thing to do before the diagnosis of lymphoma. And if you have to do a re-EBUS, please do it. But you have to complete whatever you do for lymphoma. Missing a lymphoma is one of the worst things you can do. And last but not the least is the fact that occasionally you will get a node with some granulomatous reaction and the lymphoma will be part of it. So if you don't have a good pathologist, so right from the EBUSologist to the pathologist, the link needs to be secured very strongly when it comes to lymphoma, which comes to a more complex issue. Ajay, Western world loved talking of restaging EBUS. So first of all, we could never imagine our patients go through a staging EBUS, they do some sort of treatment, and then you are looking at restaging after a while because they've responded and they have to go towards surgery. So the usual scenario is there is a 3A or something. They go through, say, neoadjuvant before any procedure. You're going to give them chemo, maybe RT, and then after that it shrinks, and then you're thinking of operating. The Western world calls it restaging EBUS, which is probably 1 or 2% of what we may be doing. How would you do that? It's the pinnacle of what can happen. It's probably one step above lymphoma also. Would you take it up at all? Would you say, forget about it, we'll just send this patient to surgery? Or would you go on a clinical staging, or would you use some EBUS tips and tricks in that?
So as you said, sir, there is a lot of technological limitations as well as a lot of expertise which is required for when you go for even staging itself. As you all know, requires much of expertise that we accurately diagnose and make the node, which is whether we make out that whether node is affected with the tumor or not. But when it comes to restaging, there's a lot of heterogeneity to the node. The thing is that the treatment, but whatever you have given as a neoadjuvant treatment, your chemotherapy or your radiotherapy makes a lot of change to your nodes. It becomes fibrotic, it becomes necrotic, it becomes hard, and it may not be yielding to your normal EBUS TBNA. Your normal EBUS TBNA for staging, as said earlier, it has more than 90% of your yield for this thing. But when it comes to restaging, it drastically drops to 60% or low. So the thing is that your normal TBNA may not be alone effective for a restaging. You may have to go for other modalities, like you may have to venture with your cryoprobe, ultradynamic cryoprobe, or you may have to use your forceps for EBUS forceps biopsies from the lymph node, which increases your chances and which makes your restaging more accurate. And this needs more expertise, which needs to for getting a confident restaging, it needs a lot of expertise, and all these techniques should be there, and it's not for just for beginners, but you need to have a good hand of about it.
So is it reasonable to say, Ajay, that in modern times, so I don't think there's strong data on it in a restaging EBUS or in a failed EBUS, where say Ravi Mehta has not been able to get a EBUS and it's referred to Ajay Ravi, is it reasonable to do a cryobiopsy or a forceps up front as a planning modality?
No. It should be an adjuvant. It should be an adjuvant to your needle procedure. You'll be using your needle biopsies, but thing is that when it comes to restaging or a retreatment after treatment nodes, your needle biopsies may not be that effective. So, but going with what we have as of now is going with your ultradynamic cryoprobe and get a lymph node biopsy as well as a forceps biopsy, which may be more helpful for this.
So let me ask Rinusha. Rinusha, if you get a failed EBUS, what's your strategy? Is anything different?
Sorry, sir, I didn't get the question.
If you get a patient with a failed EBUS, another colleague has done a EBUS, it comes to you. How would you approach this? It's a high risk malignant situation. Is there anything different strategy you would use for a failed EBUS? How would you get it? Because the onus is on you is so strong to make a diagnosis now, isn't it? Or would you just refer for a mediastinoscopy or a VATS?
If it is very high risk case or very highly vascular case, then probably surgery would be a better choice.
Right. So I think what we do is then, which I'd like to put into perspective,
That's one
is
point.
that you basically plan for the next level.
Yes.
There is no way you will not plan for the next level. You'll do what Ajay said, do your regular EBUS and hope that there's something he has missed. But at the same time, you will go full on cryo or forceps so as to make a diagnosis. That's incumbent on us at this point. Yeah. Ajay, you're trying to say something?
Yeah, one more thing which always helps us is because we do it as a routine. You have to add rows to your practice. If you have your pathologists also, it will be very good that when you are doing a restaging, your confidence very much increases.
Excellent. Arjun?
Yeah, and again, no, the restaging, especially after chemotherapy or immunotherapy, is when you will have a thing where the needle is in the node, but the node is never in the needle because it's so fibrotic at times. So, like Dr. Ravi said, that we'll have to go prepared that you're going to do this and you're going to do something more to try and get a diagnosis, because even then your diagnosis may not be as good as if you're doing it for somebody who's treatment naive.
Right. So 3-4 tips for that is, if you get a second time EBUS, Pawan, your point before I crystallize it.
Restaging EBUS question comes is when the patient is surgical candidate. If the patient is not surgical candidate and CTRT, whatever mediastinum shows doesn't matter. If the patient is surgical candidate, if you have N3 node, go for an EBUS, because like hilar node, go for an EBUS. But if not, and if the mediastinoscopy is available, then to stay in the mediastinum, surgeon is the best person when you are dealing with a post-IO or post-chemotherapy patient, because the mediastinum is very fibrous. The nodes are fibrous, difficult to identify even the margins of the nodes. So in that situation, one setup, do a mediastinoscopy and change the patient to thoracotomy and operate. That's the protocol what we follow.
Right. So just put this in important point into perspective, which will be saying some of us when we go down the line and do more EBUS, or we get these patients in the early stage of doing a EBUS. A restaging EBUS will be less common, and you have to follow the strategy of whether you're going to take it up. If you take it up for all the right reasons, because you see the nodes which are possible to sample, you will look for vascularity, as Renusha says. Make sure you do the safe thing. You will look for more nodes than you did before. New nodes may be part of it. You will sample for nodes not seen on PET also, because they may be there, especially if the original mass is more than 3 centimeters. You will follow rows like Ajay said, and then you will follow advanced strategies of cryo and forceps. So this is the 5-pronged approach to look at restaging. The same, more importantly, which you will definitely see in your practice, is a second time EBUS. Somebody has done an EBUS, it's not worked, and they come to you. Now the stakes are very high. In India, whatever you say, this mediastinopy VAT will never take off, has not taken off, and will not take off easily. So all 5 steps we talked about are very important. What did the prior guy miss? What can you do better? Is there new nodes you can sample? Do them safely. Use rows. Go more meticulously. Use the most experienced hand you have. Use all the strategies of coast to coast and what I talked about. And ultimately go to the next strategy of EBUS and cryo if required, with multiple node sampling. So that will make you the accomplished second level referral EBUSologist, which ultimately most of us will try to become someday or the other. Okay, with this detailed discussion, we wind up malignancy with one last question. Pawan, again, a Tata person, and I think we all are seeing this, by the way. It's not only oncology centers. Treatment is done, patient's happy, all is going hunky-dory. Follow-up PET shows large light up of mediastinum, no symptoms whatsoever. So this is not restaging. It is mediastinal lymph nodes which have either not responded, there's alternative diagnosis, or what's going on. So what is your approach in such cases? And I ask you particularly because you are the co-author with us on one such paper which we tried to put out on these lymph nodes, which were flummoxing in the old days but have now become much easier to handle.
Right, sir. So
1 minute if you can. Yeah.
Yes, I'll briefly describe this. PET will tell you where is the disease. What is the disease we need to define? Do a tissue diagnosis. Identify, you want to identify only node, or you want to sample the parenchyma or any other lesion simultaneously. Triage, the differential will become recurrence of a disease, either granulomatosis pathology or you have a reactive lymph node. If you do a EBUS, comes out malignancy, divert this patient towards the malignancy pathway. If it comes reactive node on EBUS and as well as the parenchymal sampling is not yielding for infection or malignancy, then either you radiologically follow these nodes or you do further invasive modalities like you do a repeat cryo, rebus with cryo or a metastanoscopy for that matter. The complex things comes is granulomatous pathology, where either you have necrotizing granuloma, you treat it as tuberculosis. If you have non-necrotizing granuloma, then take a help of other investigations. Your ultrasound characteristic, CT characteristic, tuberculin skin test, and microbiology, gene expert, and apiculture, and then tries them as tuberculosis versus a sarcoid-like reaction. Sarcoid-like reaction or sarcoid tumor protein reaction, you just follow them radiologically. Tuberculosis, anyways, we are going to treat with anti-TB treatment.
So in short, what Pawan is trying to say is that when you get PET positive lymph nodes after treating, which is a nightmare of a patient, it is incumbent of you to sample them. There is no doubt. You cannot take a PET lesion and say, go home, you're looking fine. No oncologist is comfortable and no patient is comfortable, no pulmonologist is comfortable. And don't forget, oncologists with so many immunotherapy drugs are looking for the fact that if this is cancer, we have to do something. In India, these patients could very well have tuberculosis, so you have this on your hand. And the third is reactive. So in short, you have to sample them. Now, in the old times, we used to sample them with regular EBUS TBNA. If the stakes are higher, you can go to second level modalities. No literature, this is the practice paradigm. What we were trying to point out is the intriguing part in India is when we did our series, and Pawan is a co-author. Pawan, I thought you would mention that. In our series published in PLOS, 60% of these nodes were benign. They were not cancer. So between reactive granulomatous, and that was not TB. So this sarcoid-like reaction which he talked about is so common. So more often than not, sampling will not only define it, will also lead to unnecessary treatment being stopped. We will not give ATT to these patients. Please note that. We will also define the diagnosis. We will tell the oncologist that there is no malignancy, and the patient goes with the reassurance, and all treatment comes to a grinding halt. So there's an immense value of doing that. And as I said, our paper in PLOS in 2016 or 17 put that into perspective. And that's why it's so important to look at this entity, which you will definitely face in your practice. Okay, now let's go to the radial EBUS part, which Arjun talked about at length. Saurabh, you've been given the elephant in the room. Radial EBUS, which is part of image-guided biopsy, and the old guard of CT-guided biopsy. And the CT guys are getting so good at it. They will poke their needle into anywhere. In Bombay, they will even poke it from Bombay all the way to Timbuktu, I think. So in such a situation, how would you reconcile that? What is the approach to image-guided radial EBUS biopsy versus CT-guided biopsy?
So to summarize it in 1 minute, I would say there are 4 or 5 important points when we decide regarding the sampling of which modality to be chosen. First is, I would say the lesion's location. If it is a peripheral lesion, I won't try even a radial EBUS because I know my IR guy is very confident in taking samples from those peripheral lesions which are just attached to the chest wall or attached to the pleura, and they have a good access wherever you tell them they can poke their needle and they can give you a good sample, and the yield is to the tune of 90%. The question comes when it is a lesion which is not in the center where I can just do it with my linear EBUS, where it is somewhere between the center and between the periphery. That is where the exact question of where we should be using radial EBUS. Then certain patients are there which have a significant amount of emphysema, because we all know these lesions are very common in COPD patients who have paraseptal emphysemas. In those patients, our radiologists are also not very confident in poking the needles because they know the stakes of pneumothorax are going to be very high. So in those lesions, obviously we have to choose radial EBUS over the CT guided modality. Then sometimes it depends on the type of the lesion also. When you have a GGO kind of a lesion, when you have a consolidative pattern, if you go to your IR guy, even if whatever expertise they have, they're still not very confident. But yes, if you have a solid nodule, proper solid nodule, which is even 1 or 2 centimeter away from the periphery, they'll be very keen in doing that and they will safely do that job also. Then comes upon the expertise of the proceduralist, like the person who is going to do a radial EBUS. Telling radial EBUS has a yield of 70% and range from 50 to 80% is because we all know it has a long learning curve. For a person like you and Arjun sir, maybe it's like a 2 minute or 5 minute job to find out a lesion. For a person like when I started 5 years back, we used to take half an hour in locating that lesion despite whatever discussion we have done on CT, and then we used to come out with the answer that we could not even localize the lesion. So I think so the expertise of the procedure is also important. And then what do you call it as a CT bronchus sign? If you have that sign, with even if you are biopsy forceps, you can take good samples. But again, for those eccentric lesions, nowadays it's a good role of cryo which has come up. And for a center who has a cryo, I think so that modality should be again opted for. Eccentric lesions, again the yield of a forceps biopsy is going to be on a lower side. most important, whatever we do or our CT guide do, the ultimate answer comes from a pathologist point of view. So if your pathologist is good, that even if you can give him a small sample with a forceps biopsy, he's able to give you a good diagnosis. I think so. That is the best job which he can do for you. But there are pathologists, even if you give them a good CT guided biopsy sample, they won't give you a conclusive answer. So I think so. The expertise of all of us, our IR guys, our pathologists is important. And the last and the most important point is how good your patient is going to tolerate that anesthesia, which you are going to give while you are doing a radial EBUS. Because for radial EBUS, if you are going to do, it will take you at least 30 to 45 minutes, and the patient should be tolerating that much amount of anesthesia. So there will be certain patients who have CKD, who have CAD, in which you yourself will be not very keen in posting them for anesthesia. So there you also would like your IR guy to take a sample within a 5 or 10 minutes, and he can do the job easily, in which case you might require a half or 45 minutes of anesthesia to be given to those patients.
So Saurabh has actually put a big book chapter on this in the last 1.5 minutes. Saurabh, congratulations on that. Arjun, who's winning this war right now? Is the CT guided biopsy guys winning this war? Because we are going to, this is a simple regular aided EBUS webinar. Now you'll have one day, fancy virtual bronchoscopic stuff. You have all sorts of navigation. You have, fluoro, augmented fluoro, and now you have robo. Who's winning this war right now in India with 1.5 billion people? Are we just gobbling up Western literature and trying to use their data when we know that we can use simpler methods?
I would say that no, it is all about in each institutes, whoever gets to the patient first is what is happening. There is no hard and fast rule like we've already said. Anybody in Mumbai, they would not
Interrupting,
even
diplomatic
be looking
answer. Who's winning this rule right now? Where are we heading? Where is India doing? If you take, peripheral lesions and there's 1,000 of them being, where is it? Where is it happening more? That's a pointed question to you because of experience.
But I think over years, definitely we've started doing a lot more of radial EBUS, and till 2016 we did not have exposure to radial EBUS because our processor was not compatible. And once we started doing radial EBUS, though we got the so-called navigation, the initial part is that we started getting a referral for a lot of cases, but we realized that with the learning curve, once we are through the learning curve, we are actually able to, with consistent radial EBUS, use of radial EBUS, you're able to get to 9 out of 10 of these cases, you're able to reach the lesion. And probably you're getting a diagnosis in excess of 80% in the cases where you're able to reach the lesion. You miss the so-called the advanced modalities of either a cone beam CT or the new software algorithms for 5 or 10% of your cases. So that is where I think the more we do it, more we are convinced that we will be able to hit these lesions, will be able to get a diagnosis in these lesions, and as the Western literature says, that we will also be able to stage these patients in one go.
So I think what Arjun, and to put Arjun and Dr. Saurabh's things into perspective, is it is a challenge. Choose your cases correctly, both from the point of view of technical success as well as the risk factors which Dr. Saurabh spoke about. Arjun mentions the increasing aspect of radial EBUS. Reminds me of the old days where there was nothing happening and there was TBNA and there was EBUS. Currently, we have EBUS at least happening as against nothing happening. Here, by and large, we have the struggle between choosing the patient for CT guided biopsy or radial EBUS guided biopsy. The argument stays open. It depends upon how the patient is looked at. But if I, unfortunately, with a little, sadness in my eyes, say in this country, it is still CT guided biopsy over radial EBUS. Not to mention, no oncologist, no other specialty is going to think of the word radial EBUS also. They're really not savvy. They see the patient, they do that, and then they send to Pavan, Saurabh, Renusha, or Ajay to try and figure out how to stage and how to manage. Only for staging. After that, the oncologist wants the patient back for all the reasons. So, better technology in our hands, we use it appropriately. A learning curve is there. Better combined with something. The role of radial EBUS will incrementally come down when it comes to other image guided, and probably the CBCT and all the all the other fancy augmented fluoro leading to the robo is still a Western concept. So I think time will tell us what's going on. And that's how I think Arjun has already answered the part. that it has to be combined with other technologies. Renusha, but when you take up a case, what are the extra modalities you use in radial EBUS so that you don't have to listen to Ravi Mehta saying that people are still doing CT guided biopsy? How will you enhance the yield?
Sir, firstly, once we get a nodule, we need to form a path to reach the nodule. That is like our navigation. So, firstly, in navigation, we have both VBN navigation softwares and electromagnetic navigation, like for real time navigation to identify the path. So, basically, at our center, we use both lung point and Archimedes. We will find a path to go towards the nodule. And then after confirming the path, to confirm if we have hit the target or not, we take the help of fluoro. We have two-dimensional fluoro, which is our augmented fluoroscopy or a conventional fluoro, and also we have CBCT, which gives a 3D tool-in view, so that we have a real-time visualization of the target. And once after confirming the lesion with the fluoro, we will identify the lesion with the help of radial EBUS, where we will get either a eccentric or a concentric image. Once we get the image, and then what we will be using, and these days we have our ultra thin scopes, wherein if we use the ultra thin scopes, we will go more nearer to the nodule, so that maybe our transbronchial approach can be converted into endobronchial approach. Maybe we will directly see the nodule, or with the help of ultra thin scopes, the eccentric image which we got with the radial probe can be converted into concentric image. So once we confirm that we are there near the lesion, and there comes our sampling approach. So we use both forceps and cryo, and we today only we have actually started our TBNA, transbronchial needle aspiration also. So always when it is eccentric image, cryo will definitely give a better diagnostic yield compared to the forceps. But in the presence of a concentric image, maybe cryo and forceps both are of almost same diagnostic efficacy. And also, like peripheral TBNA is also helpful to increase the diagnostic efficacy. But then the previously whatever conventional needles were there, the procedural technique was not that good. But then with the advent of this flex needles, we have actually did our first case today with flex needle, which is launched by Olympus. The learning curve is better, and it is easier to do, and the diagnostic sample what we get is also better. And then once we got that sample, we have to always have a rows beside, so that did we hit the sample or not, we will get to know exactly. And then further sampling is required, or how much material we have to take for further ancillary testing and all will be known better. So this is how we do at our center, sir.
Okay, so let's take it down to brass tacks level. I have a radial EBUS and that's all I can do. I do not have CBCT, I do not have augmented fluoro, I do not have fancy stuff. Choose your case carefully, choose a positive bronchus sign,
Yes.
choose the right lesion. Go ahead and find it, use the extra fluoroscopy to try and make your procedure much easier. So that helps Saurabh's point that it's not easy to localize. After that, use the right tool. If you have it, you can use your forceps is a conventional tool. Cryo, if you get good at it, it's a little challenge, but you can get good at it. A washing is possible, and a brushing is also possible in that area. The new needles which are coming will take time, so let's not talk of it as a current strategy. It may change in 2-3 months, and this is all you have at this point to try and make a diagnosis. The second is persistence. Doing it again and again with a little extra sampling will probably go a long way in trying to prove it. Fourth but not the least, when you're doing that and you're doing as part of a combined thing where radial is being combined with convex probe EBUS, sometimes you'll get the answer in convex probe EBUS, but not in radial EBUS, where you have to take a surrogate that it is the same thing. So this is the simplest way of trying to take this and making it a positive procedure, with hitting that 70 to 80% success yield, which Arjun mentioned and which is a literature-based benchmark. So lovely discussion on cancer. I think cancer is now permeated our minds. Let's switch to EBUS and benign stuff. Pawan, the original indications was cancer. Dr. Yasser Fuku, and when Patabi followed him, it was cancer, first cancer, second cancer, third cancer. I mean, I've hardly seen any benign literature in the beginning, and especially when we came to India, we were trying to look for EBUS and benign stuff. We have tons of benign pathologies. Can you just outline in a general thing? We'll get into specifics, but what is the menu card of benign diseases which have been more in India and which is actually part of our spectrum as much as malignancy, or if not, if more than malignancy?
Yes, definitely. As a tuberculosis endemic country, the TB is the most leading indication probably for medicinal lymph node sampling. Apart from that, we have sarcoidosis, and then even for pneumoconiosis like silica and other occupational lung diseases where the medicinal lymph nodes are enlarged. Apart from that, HIV and other HIV-associated lymphadenopathy or even histoplasma for that matter, not commonly encountered, but it's one of the differentials like fungal infection. These are the nodal pathologies which commonly come. Apart from that, other benign indications like mediastinal cyst, mediastinal benign masses evaluation, and the EBUS has been, there have been case reports for use of vascular evaluation like pulmonary embolism or for pulmonary hypertension evaluation for that matter.
So perfect. So India is a country of mediastinal lymph nodes and pleural effusions. We've been talking of this for ages. And so by and large, a lot of infective, inflammatory, and reactive pathology. So Pawan already mentioned tuberculosis, sarcoidosis. I think these two top it. But now with changing times, with so much immunosuppression, fungal and other parts are coming in majorly, and which need pointed diagnosis, especially with fungal therapy, where you can't go unlimited. And reactive lymphadenitis actually is also very common, especially now with in bronchiectasis, where the lymph nodes enlarge, and we'll talk about this later also. So in India, benign forms a significant part of what you'll do, and each one of you will go back to your setups and try and explore that even more and learn much more about it to make a difference. TB also made a difference because of the molecular aspect and resistant TB. So now when we switch to TB, let's talk to Ajay. Ajay, TB is the India's national disease, regretfully stays so, and unfortunately will continue to stay so, looks like, based on the current movement of what's happening. Let's talk of EBUS and tuberculosis. In a nutshell, in 1 to 1.5 minutes, what is the diagnostic utility? Why bother at all? I am, suppose, a naysayer. Why bother at all? Necrotic lymph node treat for TB. Why even go and diagnose and do all these things? Yeah, resistance, what's the big deal? I'll manage it and so on. Just give us some science and clinical applications of EBUS in tuberculosis.
Thanks for that question. So, as you all know, there's a prevalence. It is so rampant that there is TB all around in India. It's very rampant. So it is like that. Rather than gone are the days when we see a mediastinal lymph node or see a lesion with some cavity, directly go and start and treat it with anti-tuberculosis drugs. So right now the situation is like that in a tertiary center like ours. Rather than the pulmonary tuberculosis, it is more, what is more being diagnosed is extra pulmonary tuberculosis like a lymph node TB because of the advent of that is the effect that much is the effect of EBUS has made a change in the diagnosis of tuberculosis in our part of the country. So whenever and when coming to the technical aspects while doing an EBUS in a patient with tuberculosis, the diagnostic yield usually it ranges from 75 to 90% in different studies, and it depends on the size of the nodes and the size of the necrosis and other number of lymph nodes. All this matters when it comes to the yield of tuberculosis. And when you combine it with histopathology with other advanced molecular tests like gene experts and all, the yield again increases. So it is very imperative that when you and it is not just that we just started with empirical tuberculosis because other diagnoses like sarcoidosis as well as even malignancies are also there. So not just even being a necrotic lymph node, even a large lymph node can be necrotic even in a malignancy. So it is not correct that we start just on an empirical entity rather than going for a. You have to go for a definitive diagnosis with an EBUS and while sampling, it is also important that you take adequate sample in a saline sample so that enough microbiological tests can be sent, including advanced molecular tests like GenExpert.
Excellent. So I think, Ajay, you're talking of the fact that all TB, all necrotic areas are not TB. Even if it looks, smells, and hits like TB, it may not be that. You talked of the need to rule out resistance in modern times. And lastly, patients don't like to take empirical literature for months together, at least in an urban setting like ours, it's just a big problem. And at the same time, you could have multiple pathologies also in the same patient. So many things to guide you. And last but not the least, if you don't get a response, you at least have a baseline tissue, microbiology, and resistance spectrum in your hand so that you can guide patients. And that's a big thing. And last but not the least, these massive lymph nodes which come in tuberculosis sometimes can create a big problem. They ulcerate, they get worse on therapy, and so on. So it's an important part of identifying mixed processes to try and make a difference. Saurabh, take the sarcoid equivalent of this. EBUS in sarcoid. First of all, let's go back to history. For years, we never recognized sarcoid was there. Then we said sarcoid is there. Then now we say that we started to treat with ATT. Everybody, if it didn't respond, it was sarcoid. Now, of course, we have excellent diagnostic modalities, and God bless all of you who've trained so well, who look at tissue diagnosis. Tell us in a nutshell, EBUS in sarcoidosis.
I would say, so definitely the yield of EBUS in sarcoid has definitely increased. So whenever we used to study like 2014 data from PGI or 2016 data from AIMS or multiple center data, when used to come, now in this 2024, I would say the yield of EBUS in sarcoid would be somewhere around 80 to 85% at almost all of the centers, irrespective of whether you do a TBLB, TBNA, or whether you do EBB or all those things or not. But yes, our yield, because our pathologist, I think so, with time have improved a lot as far as the samples which you send to them, the clot core samples, the slides which you send to them. Now they are more confident in reporting them as non-necrotizing granulomas separate from TB. Previously, they used to give us a report of granulomatous inflammation whenever we used to send them a slide, or majority of the time they used to send us a report that only blood is there in the clot core. So as far as our techniques have improved, they have also improved over time in diagnosing sarcoids in these smaller samples which we send with the help of an EBUS. If you talk about the data in 2014 or 15, somewhere around 60 to 65% was the yield with alone EBUS. Definitely, if you combine all the modalities, it goes up to 90%. But now in this current era, if you talk about multiple good centers like yours, Arjun sirs, Ajay sirs, Pawan sir, all of our centers have somewhere around 80 to 85% yield just with EBUS alone. And now, if you ask about our approach, we always target that maximum amount of tissue which we can achieve with a core biopsy, clot core like maybe sample or good slides. If you are not getting those samples, then definitely we involve our forceps biopsies or we involve our cryos also, as far as medicinal lymph node sampling is considered. But rule of the book, not just an EBUS alone for sarcoid, it has to be combined with a BAL, with a EBB as well as with a TBLB, because again, it increases your yield to more than 90%, and there is less than 10% of the chance that you will miss out a patient of sarcoid after doing a bronchoscopic modality diagnosis for these patients.
So excellent. So I think in short, sarcoidosis A needs a diagnosis. Take home message needs a diagnosis. You can't ignore it. TB mimics are too common. And I remember this stage Arjun will identify when Atul Mehta stands in front of Neeraj Gupta and Atul says, why do you require to do a diagnosis? I mean, a bronch in sarcoid, and Neeraj Gupta leaps on the stage and there is a clash of tigers and titans to say that you need a diagnosis. So that is a very, very big event etched in our mind. You need a diagnosis. Strategies for diagnosis, the same Dr. Dheeraj Gupta, a sign of PGI, puts a flagship, absolutely cornerstone paper saying that a combination of EBUS TBNA, endobronchial biopsy, and transbronchial biopsy, even if you don't have parenchymal shadows, is the benchmark for hitting the 90% level for diagnosis of sarcoidosis. The third, which Saurabh put out nicely, is a microbiological rule out is a mandate so that you can make it what it's always supposed to be, a diagnosis of exclusion. So in short, if you look at the benign part of what EBUS has changed in this country, between Doctors Pawan and Saurabh, they have described it. It has been these two, TB and sarcoid, which and accurately defining them, and having a lot of sarcoid patients not get unnecessary TB, and a lot of TB patients to get the disease properly done, which is worth its weight in gold. But now let's look at the new stuff in the horizon. Renusha, fungus is coming in.
Yes.
People are getting older. Immunosuppression is at all-time high. What about the fungal and extra diagnosis? Actino, histo, nocardia, other stuff. What about EBUS and all those entities, whether it's a mediastinal lymph node or it's a parenchymal radial EBUS? Your thoughts?
Yes, sir. So basically, even if it's a parenchymal consolidation or it's a lymph node, the BAL or TBN aspirate, whatever we get, and if we are suspecting that it is compulsory an infection, then definitely microbiological studies will play a role, sir. And what these we can actually directly visualize the fungal pathology also, like if it is more necrotic black color lesion inside the bronchus, then we can directly visualize and tell maybe we are dealing with a fungal infection. And then we can directly collect the sample and we can send for microbiological studies and also serological studies and PCR studies, like our ball galactoman and fungal PCR analysis and all. We can actually send them and directly we will be able to confirm the pathology. And another thing, sir, for invasive pulmonary infections like invasive mucor and invasive aspergillosis, maybe that is that one those conditions, histopathology also, histopathology will play a role where we can directly take the tissue sample and analyze the invasion of the fungus into the blood vessels and the parenchyma. So the sample has to be sent for microbiological testing. We can also send for serological testing and PCR testing to identify the presence of fungal etiology. And for invasive fungal infections, the histopathology will definitely play a role, sir.
Excellent. So basically, fungus, not the new kid, but now the new child to adolescent on the block, invading all parts of the lung, mediastinum, parenchyma. EBUS now suddenly, as an existing tool, has become an important modality of diagnosing them. Sometimes, as I told you, mixed pathology is unknown. So it's extremely important to get a focused pathology because fungal treatment is exhaustive, is long term, needs to be focused, and comes with toxicity and cost. All 4 points are very, very important in our country, especially. So well put over there. Arjun, let's pivot to a complex topic, which has also been part of the questions put in the chat box. And I'm going through question stress as I'm watching the flow coming. I'll probably take a break after this and give credence to our amazing audience who has been so proactively posting these questions. Arjun, answer this question. Let's go fancy. There is cysts out there, bronchogenic cysts, other cysts. So EBUS guided abscess cyst drainage. Interesting. Looks very fascinating. Should it be done at all? What do you do? What precautions you take? And what's your general take on this particular aspect of EBUS and its applications?
In our travel over the last, say, 16 years or so, of course, we were initially fascinated, and this was the thing wherein you could actually sample these cysts and you attach a 20 ml negative suction syringe, and you can find a serous thing completely filling up the 20 ml, and you can see the cyst going down. So it's not that we have not done this thing before. And then as the literature progressed, we've seen that you're not achieving much with this, and there is also a risk of infection. So now, unless and until there is a doubt in the diagnosis of bronchogenic cyst, we do not aspirate this cyst. Or if there is an airway compromise which is related to the cyst, like it is famously shown by you in one of the things where you have done, wherein we only would if there is extensive compression, which we feel that it can be relieved by an aspiration so that the patient can have a symptomatic relief. But before we do this, nowadays we would give them an antibiotic prophylaxis. We would use a fresh needle. We will try and see. We'll have to do a single puncture, and if you're able to get a free flow of fluid, you drain as much fluid as possible in a single puncture and be done with that. By and large, if it is consistent with the bronchogenic cyst radiologically, and if the patient is symptomatic and it is not an emergency, patient is a surgical candidate, go ahead and subject them to a surgery. Or if the patient is asymptomatic, you can just follow them up. As far as abscesses is concerned, we have occasionally been able to drain this abscess. So we will not be able to do a therapeutic drain, but it will be more of a diagnostic drain. We are able to get a tissue from a parenchymal abscess, like you are able to access a parenchymal lesion, and you're able to drain a significant amount of thick pus. So you are able to get an uncontaminated sort of pus wherein you can try and get an accurate diagnosis. So this is the take in terms of both cysts as well as draining abscesses using EBUS.
So fascinating. Just to put things into perspective, cysts will come up. They look very smooth walled. They're often called masses. You immediately get alerted for cancer. when you cautiously go and look at it with radiology also, you'll notice that this is less likely to be there, and often they're not symptomatic, and sometimes you're fortunate enough to have old imaging showing them. As Arjun pointed out, major decision point, halt it over there. To intervene or not to intervene is a question. If you decide to do that from a diagnostic intent, then it's a reasonable thing, but cover it with antibiotics very well. If you decide to do a therapeutic procedure, be very cautious. Vidhi said, again, cover it with antibiotics. And as Saurabh pointed out in some prior point, you should be very clear in your mind that the patient is not a candidate for surgery. And if you ultimately do that and you cover them with appropriate antibiotics, the complication to watch for is mediastinal infection because the needle is directly going there. But guys, the whole literature is getting redefined. On the other side, you are sitting and poking holes in the mediastinal lymph nodes using cryo and forceps. So now you may have to revisit this literature and say, what is the difference in poking a lymph node, which is being done at least say, X number of times per month in this country, versus the fact that you're actually going through and draining a cyst over there. So I'm not really sure, and I'm raising this provocative question as we talk. But if you do it responsibly, antibiotics, right intent, good thinking, drain it, and make sure that there is no infection and do careful follow up, you may be reasonable. Abscess is a different story. The reason to do an abscess mostly is either because they're not surgical candidates, or you want to get some tissue, or you want to reduce the load and try antibiotics to the best of your ability. Otherwise, mediastinal abscesses, unless they are multiple and not amenable to surgical interventions, is currently surgical domain. Fortunately, you and I will not see that a lot. That's more the domain of maybe Pawan. We see them in the Tata spectrum with so much of extensive chemotherapy, immunotherapy going on. And if there are fungal etiology, then just like you have fungal endocarditis, probably fungus in the mediastinum is a nightmare. And that's where you have to go. And especially if that dreaded 5-letter word, which we learned in, which we know you more in COVID called mucor, is part of the thinking process. So this puts things into perspective. I think let us now give respect to our audience and take their questions. And I'll be throwing them at you guys one by one. Throwing is a strong word. Suggesting or requesting you one by one. So Rahul from Delhi puts a very complex question, and I'm going to give it to Arjun only. He's saying that how does EBUS impact the prognosis and decision making in suspected malignant pleural mesothelioma? And how do you distinguish it from other malignancies using EBUS? Part 2 is easy, Arjun. That's IST and all, I'm sure. Part 1, do you want to talk about this and any insights in this?
Malignant pleural mesothelioma, I think, since you're going to be, if the patient is a surgical candidate, then the patient is going to go for an extra pleural resection. But I am not too sure as to how, I have not really, in our practice, we have not encountered anybody wherein we've had to actually go ahead and stage these patients. Though, pleural biopsies, I know a handful of cases where we've had a mesothelioma, but again, the usual dictum in pleural biopsies would be that you have to take deep biopsies. Rigid would fare better than flexi-rigid there, and that's about it. I don't think so.
Yeah. So Rahul, truthfully, Arjun rarely hesitates. He's hesitating because there is no right answer over here. Your question is as flummoxing as the faculty who are compelled to answer it by and large. Nobody knows. When pleural mesothelioma comes, it's a nightmare anyway. You're thinking of what to do. Thanks. Fortunately, this intrathoracic chemotherapy has come now. Otherwise, it's a nightmare. EBUS would not be a major part of the thinking process. And so I think you'll go by conventional guidelines more over there. Yes, Saurabh, please.
Yeah, so recently I think so I was just taking a class on pleural mesotheliomas, and now the TNM classification for pleural mesothelioma says that regarding N1 and N2 staging in pleural mesothelioma, and that's where they have mentioned this term EBUS. So they say if you have an N2 disease, it's truly not a surgical candidate, it has to just be operative procedure. So now the TNM classification and the NCCN 2025 guideline, they recommend that a patient, if you are planning for a surgical modality for a mesothelioma, then definitely an EBUS should be done in these patients to rule out the involvement of mediastinal lymph nodes. N1 node on the same side, obviously it will be removed throughout the surgical procedure. So they say during surgery also do a lymph node dissection staging, as well as if you have an N2 node, then to surgery is out of question for these patients of mesothelioma. Then the only modality these patients has to go for is to go for a chemoradiotherapy. That is the maximum we can do in these cases.
Excellent. I think that's excellent feedback. Thank you for answering that. And Pawan, you want to add to that? Because you may have seen that in Tata.
Dr. Saurabh, sir. The recent guidelines, majority of the patient come in advanced stage, but if you detect an early stage mesothelioma, A localized disease where the resections are possible, then we need to triage these patients whether they are really a surgical candidate or not. Because they are
Excellent.
morbid
And-
surgeries, anyways.
Okay, and the next question is what you talked about. Dr. Gopalakrishna from my neighborhood in Bangalore somewhere asks basically that we've answered role of EBUS in non-small cell, but how does diagnostic performance of EBUS compared with surgical need? Do you have statistics to talk about, Pawan?
We had data present in ERS 3 years back, sir, and it correlates with the international data. I'll quote the most important Astra trial. Metastanoscopy, diagnostic sensitivity 80%, EBUS 85%, combined together 94%. So they're complementary modalities.
Sure. I think that answers it very well. The statistics are there. So it's, as we said, it's become the go-to procedure when it comes to NSLC also. At the same time, Alok wants to shift to benign and he's asking about benign stuff, TB and so on. Let's skip lymphoma. We'll come to lymphoma later. TB and PET and CT-guided biopsies. Is there data on CT-guided biopsies and EBUS in tuberculosis, Ajay? Because we asked you this. And what is the role of PET in these?
Sorry, sir, one more. Can you repeat the question?
The question is in the chat box, basically, Ajay, where what is the role of PET in benign diseases like tuberculosis, and is there any data on CT-guided biopsy versus EBUS in tuberculosis?
Sir, the role of PET, as we all know, it is just to look for the metabolic activity of lymph node. So, be it an infection like tuberculosis or be it an malignancy, the PET is going to be showing you the same. It is showing to show us the metabolic. So, there is nothing specific that it is not going to tell us it is differentiating us from tuberculosis or the malignancies. And I'm not sure about the data regarding the CT-guided biopsy versus EBUS biopsy in tuberculosis, especially for mediastinal lymph nodes. Because in our part of the country, this mediastinal lymph node biopsy with CT-guided is not. I'm not sure about the data regarding CT-guided biopsies for tuberculosis.
Anybody wants to add to that data? Because to my knowledge, nobody's going to do a study of CT-guided biopsy versus EBUS. It's going to be a practical adage. So anything from you guys, any data you're aware of between on that front? I take it as a no and I see nods in the lateral direction. Okay, so lymphoma part I think was addressed. Dr. Alok had also asked. Arjun extensively talked of lymphoma being a science where we have EBUS has picked up a lot and adding cryoforceps, etc., plus maybe 19. So increasing the yield of lymphoma by using all the modalities we talked about earlier will go a long way in making you a EBUS specialist who can actually give a diagnosis of lymphoma because you thought it through and reached a level of expertise. At the same time, Dr. Raman is asking about benign cystic mediastinal masses, and we talked about that, Dr. Raman. Indications of EBUS in suspected malignancies was extensively covered. Dr. Ramanand wants to know by and large. And then there's an interesting thing Dr. Hiten from Mumbai asks, what are the limitations of EBUS in distinguishing benign and malignant lymphadenopathy with IPF, or let's take ILD. We'll expand the question. And how can these limitations impact clinical decision making? Who wants to take this one? Saurabh?
Yes. So I think so. The question, I'm not very sure about the question. The question
ILD and lymph nodes. Actually, it's part of the questions I had, and let me see who I was going to ask this question to. It was supposed to be a question for Ajay. Ajay, you take this one then. ILD and mediastinal lymph nodes. Give us some enlightenment on that.
So basically, the lymphadenopathy and associated with interstitial lung disease, this is not going to make much of a difference in the diagnostic part of an interstitial lung disease. Rather, we see mediastinal lymph nodes in ILDs, most of them are inflammatory, and the sampling them may not be helping us with the diagnosis of the disease per se. But considering a patient with ILD on immunosuppressants and steroids for long term, the high chances that he may having an opportunistic infection like tuberculosis, especially in our country, is very high. And so that lymph node, when detected in an ILD, to sampled to rule out mostly the infections. And rarely there are some malignant process which can be a second pathology can be associated. But mainly in an ILD, sampling a mediastinal lymph node is to rule out persistent opportunistic infections in a patient who is immunocompromised.
Right. If I can add to that, we've actually studied, but let me pivot to Arjun and make it challenging. Arjun, you do cryo for ILD. Okay. You see a lymph node of 1.5 centimeters. Are you going to say reactive as per the famous radiology texts of Nestor Muller and so on? Or will you say, I have a EBUS, I'm going in with the region, why don't I sample this and look at what's going on there? Your take on it.
So if it is going to be less than centimeter and a half, then we will probably see whenever you have a lymph node which is enlarged and you're going to be doing a procedure anyway, we would go ahead and sample the lymph node also if it is sufficiently enlarged, because this is where you're going to get a tissue wherein you're taking it under vision. It will add to whatever the pathologist sees in histopathology. In terms of supposing you're looking at an interstitial lung disease where the possibility is sarcoid. So again, the lymph node there can give you possibility, can help the pathologist. So if you're going to be doing a procedure and you're going to be doing a cryoTBLB, if you have a sufficiently enlarged lymph node, we'll go ahead and sample the lymph node.
Okay, so let me add to this. So Pawan, when you worked with us, you had this, you saw us putting this. I'm trying to answer this question. So we decided that these lymph nodes, we went and looked at literature. ILD plus lymph nodes, major discussion, can be a separate total discussion. And we realized that in India specifically, with especially traction bronchiectasis, you had a little larger lymphadenopathy. Existing literature, more from radiology, called it reactive. None of us knew. So we said the same thing question I asked you, Arjun, that when we're putting in a rigid scope for a cryo, why not sample the lymph nodes too? So I think we've reached somewhere close to 75 to 100. The value addition, so we have found a good, most of them to be reactive, but in around 10% of these nodes, we found diagnosis changing entities. HP, for example, has granulomas even in the lymph node. I can see
Lymph node.
Renusha nodding, and that's an important observation. Some of them turned out to be some other coincidental diagnosis, such as malignancy, which is also described with ILD, more IPF, but others, and so on. So I'm not going to get into details. Ajay's points on post-infection is taken, but these are naive patients going through ILD cryobiopsy. So yes, these lymph nodes are majorly reactive. The EBUS can be done if you are planning another procedure, whether you should do a standalone EBUS. If we put out a paper which we put as an abstract, we will say yes, probably. In fact, that's a discussion I have to take up with the researcher tomorrow. And this is still a question which needs to be answered, and centers may having different approach. So this is a long answer to this question, close to my heart, because I think we worked on that also. I'll go on to the next question. I think the others which come from Dr. Sharma is which we've already answered. The role of EBUS in benign and in like sarcoid lymphoma, sarcoid tuberculosis, lymphoma would be malignant, and of course, role of EBUS compared to CT PET. Now we've answered this, but Rirusha, do you want to put it again into perspective? CT PET guided therapy versus EBUS guided therapy. So I'm shifting the stage to 10 years ago when you probably were still in training, but you know the literature. Would you answer that in 1 minute? The role of EBUS compared to just doing CT and PET?
Staging EBUS and PET, sir.
No. EBUS, that's simple. You have, if I'm sitting in a small part and I get a CT scan, my oncologist will just go ahead and diagnose. But now you are sitting in Hyderabad in high-tech city and you want to do an EBUS. Will you categorically say there's value addition in EBUS compared to CT and PET? It's a question coming again, so I wanted you to answer it.
Like PET will only tell us if it is the lesion is there or not, but what exactly are we dealing with? PET will not give us the answer, no, sir. So definitely we have to do EBUS to identify what pathology we are dealing with.
Exactly. So I think that says it all. One sentence says it all. I'm just reiterating it because the question came up, in after our discussions. Dr. Ravindra is asking a very interesting question that from Indore, that can EBUS guide bronchoscopic interventions like BT bronchial thermoplasty for benign conditions? So one is BT is gone. December 30th, no more catheters available. All of us are scrounging. I think 4 centers on this have BT. Scrounging to save some catheters for the 5-6 patients we can do, or the 2-3 patients we can do if patients come up with non-T2 diagnosis for us. But I think more importantly is, can EBUS help in other things like relapsing polychondritis or tracheobronchopathia osteochondrioplastica or something like that? Who wants to take that? Ajay, you want to answer that question?
Not really. I'm not. This seen in the textbooks like the old radial probe with that balloons and all, which which helps us to see the thickness of the trachea and all the cartilage in the body.
Yeah, it's a googly. Anybody wants to take the googly? Yes, Pawan.
I'll take it, sir. So, sir, airway wall assessment is a phenomenal thing. We don't have that probe. We have never done it. We just read the literature. You put a probe, put a balloon around it, get an abutment or attachment to the wall, get better picture on the wall, identify the cartilage. That's the purpose of. Is there a cartilage has been disintegrated or not? That's the purpose of doing that procedure. Mostly in malignancy, thyroid malignancies and esophageal malignancies, whether they have eroded the walls or not, operable or non-operable. Comes to relapsing polychondritis, bronchoscopy, you can identify there is a swelling and there is a extrinsic EDAC like phenomenon or bronchomalacia. But in wall, I'll not go into details of that, but the cartilage wall will show you there is a swelling, the submucosal swelling. So there is a fragmentation of cartilage and there is a swelling in a cartilaginous portion, sparing the posterior wall. That has been described in literature, not been validated in a series, but there are case reports on that. So can give you, but ultimately tissue is the truth. You biopsy it and you prove it. The question what from the audience has been asked, what are the other applications? So there have been literature on measuring the stent thickness, stent diameter thickness with the help of this balloon. Then integration of the wall assessment for brachytherapy, and in terms of lung transplant for rejection, whether there's a rejection phenomenon happening in the in a distal part of anastomosis can be judged on basis of this wall thickness.
So excellent point. This is the somebody who will reach the last part of EBUS, and Pawan is trying to write a book on EBUS, so he knows all these things. Most of people will not read it. Now, the question here is very clear. History, and we'll make it fun in the last 30 seconds. We bought this little radial EBUS with the balloon, and we tried to do this in cases. We looked at some, relapsing polychondritis. We were looking at choke points in stents and all those things to answer the question. Guys, it's a learning curve. You have to be really into it. And you have to put it over there, know the 6 layers of the bronchial wall and all. So theoretically, they're practically challenging. If you get into it, God bless, you should be taking a webinar on this stuff. So anyway, it's now 10:29. I think we've had a interesting, long, extremely enriched session. I would like to conclude by, first of all, thanking the organizers, IAB and Dr. Amita Nene and Mehul. Mehul has nicely appeared. Mehul, you're looking very good in the beard, if I may say so. And I would like to thank you for giving us an opportunity. I would like to to compliment Dr. Arjun on a very nice talk, which was also mentioned in the chat box. And I'd love the enthusiasm and the knowledge of the faculty in giving insights into aspects which are challenging. At the same time, some of these are not there in literature. Again, thanks to Olympus and Mankind with Nitin spearheading the whole venture so as to make this possible. And I think this is a grand march of the IIB in trying to make a topic reach center stage, even going to the north, to the 4 corners of the country. So with this, we hand over back to Mehul, and a personal thanks from me again. Thank you so much.
Thank you, sir, for spearheading this, for making this webinar very interesting. This was a broad topic, and we were thinking whom to call for the moderator, and we could think of no one else except for you. So, Ravi sir, thank you for this moderating this difficult webinar. This was actually like a conclusion to all the webinars that we have done, and now taking clinical scenarios and discussing them. That was the most difficult task. Again, Dr. Arjun Srinivasan, an excellent talk, insightful talk. In fact, it is always a pleasure to hear you and always learn from the experiences from the so many cases that you have done, that the do's and don'ts that we learn from you. And coming to our own faculty, I mean, all the faculty were so insightful. They had all their experiences poured into this. Dr. Pawan, Dr. Ajay Ravi, Dr. Saurabh, and Dr. Rinusha. Thank you all for being here, and thank you for sharing your experiences and making this webinar insightful. Yes, sir.
Yes, and my gratitude to all the people who posted questions, and my apologies to those we could not cover. Thank you.
Yes, sir. So I'm taking you to that. So we had more than 2,100 logins, and obviously there are going to be a lot of questions for this. So I think for all the questions which have been unanswered, you will have a one-on-one session. We have a hands-on which is going to happen in each one hands-on session in each zone of the country. There you can catch a hold of all of them and then ask, bombard them with as many questions as you want. Sir said, sir will be firing questions. You can fire questions to them, and they'll be more than happy to help you out. So with this, I would like to also thank Olympus and Mankind for helping us get this webinar up and running. We have completed 9 webinars and we have 1 more to go. And beyond that, post our NAPCON Pune, we'll be having the hands-on workshop sessions. So thank you all for being here. Good night, and I'll see you in the next and the last webinar.
Thank you.
Thank you.
Thank you all. Thank you.
Thank you.